It's the only brain in the face that doesn't articulate with the maxilla. So it's a point of contact. So joints are movable joints that allow for complex, highly coordinated, and purposeful movements to be executed. Now, some joints have lots of movement, like the ball and socket joints we talked about. Some joints have very little movement. Some joints don't have any. So an articulation is the point of contact between bones. Joints are mostly very movable, but some are immovable or only allow limited motion. So classification of joints. Structural classification, joints are named according to whether they are fibrous or cartilaginous joints, or if they're synovial. So it's really between fibrous and synovial. Functional classification. Synarthrosis, I want you to know this really well, so you want to highlight this real big in your notes. Synarthrosis are fibrous joints. They are fibrous joints. A perfect example of synarthrosis would be suture joints of the skull. That's the only place we have sutures is in the skull. And kyphosis, which is in the gum of the tongue. Okay, kyphosis. And I'll show you a picture. So, do you think there's a lot of movement here? No, there isn't, right? So synarthrosis, you want to think no movement. Are very, 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 very. Synarthrosis. Now, amphiarthrosis. Amphiarthrosis is a joint that permits very, very little movement, such as in between vertebrae. Joints in between vertebrae. Diarthrosis, you're going to see lots of movement. So you want to highlight that real big in your notes. Diarthrosis, lots of movement. A perfect example would be your hip joint or your arm, okay, your shoulder. Lots of movement because of that ball and socket. So they could be considered diarthrosis. So let's stick with fibrous joints or synarthrosis. Joints in which ligaments connect to bones. Sutures are found only in the skull. Kyphosis between the root of a tooth and the alveolar process of the mandible or maxilla. And I'll show you a picture. So here's our sutures, obviously. Okay, these are all fibrous joints. So what's the name? Starts with an S. Synarthrosis. Synarthrosis. And here's kyphosis. And there's no movement. Fibrous joints. Cartilaginous joints or amphiarthrosis, they have a little bit of movement. A little bit of movement. Okay, I want to introduce you to some more terms. Rotation consists of a bone pivoting on its own axis. Circumduction moves a part so that its distal end moves in a circle. Supination and pronation. This is easy to remember. You want to think of supination as holding a bowl of soup. Okay, that means the palms up. Supination, holding the soup. When you pour out the soup, that's pronation, palm down. Supination, pronation. You okay with that one? Supination, palm up, pronation, palm down. Symphysis, joints in which a pad or disc of fiber cartilage connects two bones. Okay, synovial joints. Synovial joints, we want to think of diarthrosis, which is lots of movement. I want you to know the structures of a synovial joint. We're going to have a joint capsule. We're going to have a synovial membrane. We're going to have that articular cartilage, joint cavity. We're going to have menisci, ligaments, and we're going to have bursa. You ever heard of bursitis? What's bursitis? Inflammation of the bursa. And where do we have bursa? And basically all of our synovial joints. Bursitis. So you want to know synovial joints are freely movable joints. You want to know the joint capsule is a sleeve-like casing around the ends of bones that binds them together. The synovial membrane is the membrane that lines the joint capsule and also secretes synovial fluid. And we already know about hyaline or articular cartilage that's going to be at the ends of the long bones. The menisci are pads of fiber cartilage located between articulating bones. The bursa or synovial membranes are filled with synovial fluid that cushion joints and facilitate movement. So what do you think this is? Just looking at it, without doing any tests, it really could be one or two things. It could be gouty arthritis, what we call gouty arthritis. Do you see how swollen and how inflamed the elbow is? But how could we prove or disprove the gout?
They usually form as a
Yeah, we do blood work, and if that uric acid is high, then we can say, yep, this is gout. Okay. Otherwise, it's probably olecranon bursitis. Olecranon is olive, so olecranon bursitis. Both are very, very painful. I don't know if there's a difference with that in the pain. So what we can do is, here's the shoulder joint, and if this is bursitis, we can go into the bursa, and what are we doing here with the syringe? And what's the transducer for? This is really cool, actually. Anybody know what the transducer is for? You know, in the past, the doctor would be kind of go in kind of blind, right? Like they would think they were in the right area, but what's this transducer do? Yeah, it's like an image thing. So it'll come up on a monitor, and the nurse will look and direct where they should put that syringe, which is really kind of cool. Yeah, bursitis. If it's in the shoulder, it can actually, the pain can radiate to the chest, and the patient will go in thinking they're having a heart attack. That's how painful bursitis is. different types of synovial joints, and you have to know them all, okay? So, we have something called uniaxial joints. Uniaxial joints. And two big examples of uniaxial joints would be hinge joints and pivot joints. Hinge joints and pivot joints. Do you know what a perfect example of a hinge joint is? Yeah, you definitely know that, right? Another one would be the knee. And then we have biaxial joints. Two perfect examples would be saddle joints and condyloid, and I'll show you pictures of these in a minute. Multi-axial joints, well, it kind of tells you in the name, multi, that it's going to have multiple range of motion. So you got your ball and socket, and you got gliding joints. They're two perfect examples of multi-axial joints. So uniaxial joints are synovial joints that permit movement around only one axis and in only one plane. Hinge joints are those in which the articulating ends of bones form a hinge-shaped unity that allows only flexion and extension. And remember, so if we do this, what are we doing? Like flexing. And if we do this, extending. Okay, good. Pivot joints are those in which a projection of one bone articulate with a ring or notch of another bone. Biaxial joints are synovial joints that permit movements around two perpendicular axes in two perpendicular planes. So here's a perfect example of a uniaxial joint is the hinge joint that's the elbow. Perfect example. Pivot joint would be the bends of the axis rotating against the atlas, or the head of the radius rotating against the ulna. You know, when you do this movement, the bones are rotating. So you want to know those. Okay, that's two perfect examples of uniaxial. And I already said another example of a hinge joint is the knee. Biaxial joints, the saddle joint would be the joint of the thumb, and the condyloid joint would be the alento-occipital joint, which is the atlas, right? And what's this? Occipital. What's the occipital? The back of the skull. So that's the condyloid. That's an example of the condyloid joint. So the condyloid joint, the occipital bone fitting into the atlas bone of the vertebrae. Atlas being the first cervical vertebrae. Multi-axial joints, you got your ball and socket, perfect examples, shoulder and hip. Which one has more rotation? The shoulder or the hip joint? You got it, the shoulder. The shoulder. Gliding joint, another example of a multi-axial joint, articular processes between vertebrae. So the shoulder joint is the most movable joint because of the glenoid cavity. So the glenoid labrum lends depth to the glenoid cavity. Structures that strengthen the shoulder joint are ligaments, muscles, tendons, and bursa. The humeroscapular joint is the joint between the head of the humerus and the glenoid cavity of the scapula. And in layman's terms, we refer to it as the shoulder joint. So this is have the bursa here, we have this synovial cavity, and here's this glenoid labrum. So it's going to allow for lots of movement there in the shoulder. Classic hinge joint is going to be the elbow joint. And this is what I was talking about, electro non-bursa. And that's where, if it's inflamed, we call it electro non-bursitis. And then trauma to nerve results in unpleasant sensations of the fingers and part of the hand supplied by the nerve. It's actually called, what do we call it? When we hit our funny bone?
Not funny.
It's not funny, right? It really hurts. And that's because of those nerves. Next semester, we're going to do a little experiment to show you about nerve pain and how, with nerve pain, a nerve can be impinged in one area, and you may not feel it in that area, but you'll feel it somewhere else. And that's what's tricky about treating nerve conditions, nerve pain. Like the sciatic nerve, it originates in the back, the lower back, it goes all the way down to the foot. Well, some patients may not have any pain in the lower back at all. It may be in the buttocks, it may be in the lower leg, it could be in the foot. So we'll talk about that, and we'll see how you get to experience a little bit of that nerve. But it's temporary. So only the radius articulates directly with the carpal bones distally. That's why with that scaphoid bone, it's frequently broke because, like I said, it hits up against that radius bone. And I already talked about the fractured scaphoid can become avascular, and it will require surgery to remove the chronic valve. The thumb, the only thing I want you to know about the thumb is that it has lots of range of motion. It has something, what we call opposition, and you're able to move it. It enables you like to pick up change and things like that. If you had to lose a finger, don't lose your thumb. The thumb joint, it has flexion, extension, adduction, abduction, circumduction, and opposition. What is adduction? Yeah, so it's closest to the midline, right? Adding to abduction or abduction is further away from the body. The knee joint on slide 32 is the largest and most vulnerable joint. It's subjected to 7 strong forces during athletic activity. We see this all the time in my favorite sport, football. We're constantly having knee injuries. If you're working in the ER, that's what you're going to see a lot of, knee injuries. Okay, vertebral joints. I want to talk about the slip disc. So I'm going to show you what the vertebrae should look like. So here's all of our blood vessels in the vertebrae. Here is the nucleus pulposus. On each side of the nucleus pulposus is the annulus fibrosus. Annulus fibrosus on each side of that nucleus pulposus. It's perfect here. This is what ours should look like. However, However, if we have a slipped or a herniated disc, look what happens. So that nucleus pulposus is moving towards the what? The nerve. And that's what causes so much pain, because the body weight and the pressure always goes down. So with this herniated disc, as soon as it hits that nerve, it's going to cause lots of pain. Right? And then in the elderly, we can have something, it's degenerative disc disease, and that's where this is basically all gone, and it's just bone on bone. Okay? That's the worst, because it is really hard to treat. There's not really a whole lot we can do, but pain management. It's really painful. The other thing that can happen is that we can develop bone spurs on the vertebrae. And that's painful because they will, if they get big, they're going to hit these nerves. So that's a whole other issue. Okay, range of motion. I used to talk about this a lot with my physical therapy students or massage students, because they do a lot of range of motion tests. Why? So if a patient has an injury, what do? We check their range of motion, right? We document it, see what the range of motion is, and then we're going to do physical therapy, and we'll keep testing that range of motion, hoping that the range of motion will get better. Okay. So range of motion can be measured actively or passively. What does that mean? What's active mean? They're doing it themselves. Passively, we're doing it for them. So in the very beginning, we'll probably be doing it for them. Okay, and then they get better, then they do it. The other thing about range of motion, and this sounds horrible, but we ask the patient what their lifestyle was before the injury. So if they say, I'm very active, I play golf, I play pickleball, then we will do everything we can to get them back to that lifestyle. But if they say that, I didn't really do a lot, I'm not active, then, we don't, we don't put a lot of pressure on them to get that full range of motion back, because it may not be relevant, and it would hurt them more than help them. I know that sounds horrible, but that's what we do, especially, and like I said, if they were inactive to begin with. Some more flexion, extension, hyperextension, we'll talk about all of those. So, angular movements change the size of the angle between articulating bones. So here's what I want you to know about flexion. You want to know that it decreases the angle between bones, and then it folds one part on another. And that's exactly, if you hold your arm out like this, and you flex it, you're shortening or decreasing that angle, right? So you have your arm like this, and then you're going to flex, you're shortening that angle, and that's what it's saying there, decreasing the angle. Extension is just the opposite. Now you're increasing that angle. Okay? Don't confuse the two. This is the verbiage I would use on the exam. Hyperextension is stretching or extending a part beyond its anatomical position. So if we put our head all the way back, okay, that would be hyperextension. plantar flexion increases or dorsiflexion decreases the angle between the top of the foot and the front of the leg. Plantar flexion, this is how you remember it. You're planting your toes into the floor. Okay, that's plantar flexion, planting the toes into the floor. And that's going to increase the angle between the top of the foot and the front of your leg. Can you see that? It increases. That's plantar flexion. Dorsiflexion is when you take your toes and you point them to the front of your leg. Okay, now you're decreasing the angle between the foot and the front of the leg. Do you see that? Okay, all you have to remember is one, and then you know the other one's the opposite. So plantar flexion, toes to the floor. You're planting the toes on the floor, and it's going to increase that length between the top of the foot and the front of the leg. You see how it's increased? And then dorsiflexion, now it's decreased. The length is decreased. Are we good on that? Adduction, abduction, I usually say abduction to avoid confusion, moves a part away from the median plane of the body, where adduction moves a part towards it. And these, I'm not going to go through all of these. These are really for you. I'm going to point out some though. Let's see. Protraction is moving a part of the body forward. So this would be protraction. This is hyperextension. Here he's moving the back all the way. Okay, here we go. So adduction, he's taking his arm and his hand and moving it to the middle of the body, where with abduction, he'll move it away. Okay, for slide 48, inversion and eversion. Confuse these, so I want to make sure that we have this down. I'll come back to that. Okay. Inversion is when the patient walks on their little toe side of the foot. Okay. That is inversion. Eversion is where they walk on their big toe side. You can see this in patients if they wear sneakers, right? You can see where it's worn on this side or it's going to be worn on this side. This can cause problems later in life with knee pain and lower back pain. If they're diagnosed when they're little, we can give them corrective shoes to wear, and it usually will take care of this problem. Okay, but please don't confuse the two. I think I went over some of these. You want to know the definition of rotation, circumduction, moves in the circle. You can kind of remember that. They both start with C. We talked about supination and pronation. This is just showing you how, this would be flexion of the fingers and extension. It's just using your hands to show that. Abduction, spreading the fingers apart. Adduction would be closing the fingers. And here's your plantar flexion again, toes pointing to the floor, dorsiflexion, toes pointing to the front of your leg. Which one shortens the length? Between the foot and the front of the leg. You got it, dorsiflexion. So bone development and the sequence of ossification between birth and skeletal maturity affects joints. Older adults, they have a decrease in the range of motion even without any injuries or any pathologies. It just changes when we get older. Changes in gait. They're going to be talking when you get into core about watching the way a person walks, their gait. We can tell a lot. If they're kind of like shuffling like this when they're walking, that's usually indicative of Parkinson's disease. Right? If they walk like they're staggering, like they're drunk, it could be MS, it could be Gary's disease. But it can tell us a lot just by watching the gait. Skeletal diseases manifest as joint problems. We can have, I want you to know that abnormal bone growth is called lipping. We refer to it as lipping. In layman's terms, we'll say somebody has a heel spur, right? But really what it is abnormal bone growth. And we can go in and shave it, but sometimes it'll come back. And this is an osteophyte, or lipping, or excessive epiphyte. I don't know if you've ever had a spur like this, or it can be really, really painful. Here is a healthy spine, and here's one with osteoarthritis. And like I said, you notice how there's no stasis here. It's literally bone on bone. I have patients with this. I just feel so bad for them because there's, like I said, there's not really a whole lot we can do. And it's worse in the morning. So you want to think of osteoarthritis as being worse in the morning, and after they get up and they move around, they start feeling a little better. With rheumatoid arthritis, it doesn't matter. They're in pain all the time. Bursitis is caused by prolonged pressure, repetitive exercise, or trauma. I want you to know that. It's usually due to some repetitive movement that we're doing that causes bursitis. Osteoarthritis, I want you to know, involves the hips and knees first. And we give NSAIDs to help with the pain. What's NSAIDs? Aspirin, yeah. Now here's where it gets complicated in our system. So let's say I'm your patient, and I have osteoarthritis. And, you can tell me, well, aspirin works really well for that. But then I say, well, I've got kidney disease. I can't take aspirin. Then what could you suggest? Tylenol, right? But then, this is Penny with all the problems, I have a liver issue. Can't take Tylenol. Now what are you going to suggest?
Icy hot.
Icy hot. Yeah, I could do that. here, guys? What are you gonna tell me? Oh my gosh, I'm in so much pain. Well, I can't take Tylenol, I can't take aspirin, and I can't take, most of your narcotics has Tylenol or.
So you can switch to the other.
I hate gout.
Eat a magic brownie.
There you go. There you go. Right? Maybe marijuana would help. Right? Okay. But you want to explain to your patients, because I, suggested marijuana to my patients, and they'll say, I can't do a bong, I can't do that. That's what my grandson does. I can't do that. But there's different delivery systems, right? And it can help. Some things don't even have to go with as far as marijuana. What else could we use? CBD oil. We have to find something though. I hate when doctors tell patients you're just gonna have to live with it. Well, that's easy for them to say, right? We have to do so. We have to find something. Joint dislocation, pains and soft swelling, soft tissue swelling. We have sprains. Rheumatoid arthritis is different than osteo. Okay, osteo we think of as an older person's disorder, right? Rheumatoid, it can happen to anyone. Children are born with rheumatoid arthritis. It's a chronic inflammation of many tissues, and it's not just joints. We think, it's the fingers and the toes and the knees. Yes, that's true, but it also affects organs. And so juvenile arthritis, the symptoms are a rash, high fever, and they're going to have hepatomegaly, which is swelling of the liver, and splenomegaly, which is enlargement of the spleen. Okay, so it affects the organs, and usually patients with rheumatoid arthritis, it does affect their lifespan. It's shortened because of it, and they usually will die of respiratory issues because of the rheumatoid arthritis. And juvenile arthritis, we don't like to give a lot of pain meds. Why? Because they're kids, and what happens when they get into their 30s and 40s and 50s and 60s? That's exactly right, and it gets worse as they get older. Gouty arthritis, excessive blood levels of uric acid are deposited as sodium urate crystals. It can occur in any joint of the body. However, the most common joint is the big toe. It's really strange, and it's more common in men than women. However, because it is a metabolic disorder, just like diabetes, if someone has diabetes, they're more vulnerable to having gout. Anybody had gout in here before? Oh my goodness. My husband was a Marine, real big guy, and real tough. And he had gout in his big toe, and he couldn't, just the sheet touching his big toe, he would just go crazy. That's how painful gout is. And I've never seen him, with pain except for gout. I used to tease him. I was like, really? It's just your toe. He's like, it hurts. And don't worry about the rotator cuff muscles. We're going to talk about when we start the muscle chapter, which is chapter 10. We only have 2 more chapters left. Chapter 10, chapter 11.